There's a very quick evolution on the treatment of patients with newly diagnosed multiple myeloma. I think the common theme of ASH and the common theme of the clinical evidence in the last couple of years is that the very strong role that CD38 monoclonal antibodies have in newly diagnosed setting. That has been demonstrated and confirmed in the Cassiopeia trial with DARA VTD. That has been demonstrated in the Griffin trial with DARA VRD. That has been illustrated on the Master trial with DARA KRD and on the Manhattan trial with DARA KRD. And at the ASH this year, we're seeing from the German group, the isatuximab VRD giving for an extended 18 weeks induction, producing very high rates of response, including MRD negative response that is superior to what is achieved with VRD. In the patients who are not amenable to transplant, you have the very strong evidence with two trials, the Alcyon trial and the Maya trial, showing not only improvement in PFS but also improvement in overall survival. So I think monoclonal antibodies, CD38 monoclonal antibodies are here to stay in the upfront management of most patients with multiple myeloma. Several questions remain. I think one question is, what is the best combination? Does it really matter what PI you're combining with, or what IMiD you're combining with? I think it does, but I think only time will tell. I think there are other questions like the optimal duration of the monoclonal antibody. That has not been answered. Many of those studies continue the monoclonal antibody until progression, but the lack of benefit of daratumumab when used as maintenance on patients who receive daratumumab-based induction and consolidation on the Cassiopeia trial put that into question, whether patients need indefinite therapy with CD38 monoclonal antibody. And the last question, perhaps important, is as the therapy evolves and becomes more effective in myeloma, we have fewer and fewer patients who do not respond or who have a transient short-living response. But those patients will be very selected, and will be patients with a very worse biology. So it kind of, I wouldn't say creates a problem, but frames a problem. Those patients with very high-risk disease that definitely will need therapy other than quadruple therapy. It's pretty clear that even the best quadruple combination is not optimal in every single patient.